Welcome to the second module of Fallopian Tube Pathology. I'm Samira Rashid. I'm a breast and gynae pathology fellow at Hammond Medical Corporation. In this module, we will go over inflammatory lesions affecting the fallopian tube, common benign lesion of the fallopian tube like adenomatoid tumor, and in some detail, we will be discussing the pre-malignant and malignant lesion of the fallopian tube. Acute salpingitis is not very common. However, this is associated with pelvic inflammatory disease, sexually transmitted disease, and intrauterine device. Here, this is a section of a fallopian tube. I have a lot of neutrophils. So whenever you see these two nuclei, bilobe, trilobe, these are neutrophils. Also, I have some plasma cells, some lymphocytes, but predominantly this is acute inflammation. This acute salpingitis can spread from the uterus and to the uterus, usually seen in young reproductive age women associated with sexually transmitted disease, pelvic inflammatory disease, or intrauterine device. The fallopian tubes in these cases are enlarged and edematous. Chronic inflammatory salpingitis is rather more common than acute, but in most cases, we see a mixture of both. So here I have sheets of lymphocytes and some plasma cells as well. In many cases, because the process is chronic, so we have these lymphoid follicle formation. So I have this sheet, like round sheet of lymphocytes. And in some areas, it looks like it has a germinal center. So it's like a lymphoid follicle. Yet again, this is just chronic salpingitis. Now, this was an extreme case of chronic salpingitis that resulted in a tubal ovarian abscess. This patient presented with bilateral adnexal masses. And there was some suspicion that are these masses just inflammatory, or there could be malignancy. So they did hysterectomy with bilateral salpingo-oophorectomy and sent us the specimen for frozen section. I took touch imprints from the masses, and this is what the friable mass that was inside those round structure it looked like. No viable cells here, just looks like there is necrotic debris. And this is the frozen section slide. Looks like there is some sort of crystalline material or some granules here, which are like fractured crystalline materials sort of look, surrounded by chronic and acute inflammatory infiltrate. On the permanent section, you have the diagnosis. So this is a lesion that we see not just in the tubal ovarian abscess, but more commonly in the tonsils. And also we see them in the neck cervical lymph nodes. These are sulfur granules and some radiating filaments, and surrounding this area I have macrophages, acute inflammation, chronic inflammation. So this is tubal ovarian abscess associated with actinomyces. Another chronic inflammatory disease of the fallopian tube is salpingitis is the Mechanodosium. Basically, this is just outpouching and diverticuli of epithelium and muscular hyperplasia. This is a cause of infertility and increases the risk of ectopic pregnancy, but a completely benign lesion. This is an exam favorite question. This is a lesion that we see quite frequently in the male genital tract, in the female genital tract, in the peritoneum. It looks like this is a vascular proliferation, but when we do our vascular markers, which are CD31, CD34, these are completely negative. What it does stain for is WT1, calratinin, which are mesothelial markers. So this is adenomatoid tumor. Positive for calratinin, WT1, D240, and negative for CEA, BARIP4, EMA, vimentin, and all the vascular markers. This is a benign lesion of the fallopian tube. More commonly, this lesion is found in the ovary. So I have this proliferation of epithelium. In areas, it looks like it's making a gland, but in other areas, it's just some epithelial lining. And the other component of this lesion is the paucicellular stroma, which almost looks like spindle cells. So this is a adenofibroma, completely benign lesion and more common in the ovary. This is another benign lesion that is not very common, but not uncommon either. This is just proliferation of the fallopian tube lining. It's called a serous papilloma. So this is just fallopian tube lining, no atypia and no muscular layers. So it has to be distinct from the fimbriated end of the fallopian tube. This lesion is extremely common in the uterus. You must have seen so many cases. One of the most common specimen in the histopathology lab. And here you can appreciate some whirling appearance, usually whirling more seen on the gross appearance. Here I have interlacing fascicles of spindle-shaped cells. So this is a leiomyoma. Yet again, very important to look for necrosis, atypia. And if you have any of those, then start counting mitosis. Fallopian tube epithelium, extremely important to examine this, especially if the patient has any tumor of the fallopian tube or adnexa. Also, if the patient is carrying BRCA mutation. Now this, in this picture here, you can see that I have really nice cilia. It's all ciliated, a bit overcrowded. It's not a single cell layer. However, the cells are not hyperchromatic and they are polarized, orderly arranged. So this is tubal hyperplasia. Rarely it can mimic the intraepithelial carcinoma. So we will keep that in mind. Another benign mimicker of intraepithelial carcinoma is the Cautery effect, so common in surgical specimen. Yeah, I think this could be a good example. So I have two fragments of fallopian tube epithelium. One is not cauterized and the other one is cauterized. And this one, it really looks scary, but if I just pay close attention to it, I can see that the nuclei are so elongated. This is just too long. And even the tissue where that is underlying, it looks like there is some thermal artifact here. So this is all cauterized, and this is not very important to make sure that there is no artifact if I am assessing a specimen for intraepithelial carcinoma. Now, it is not possible to talk about fallopian tube pathology and not talk about BRCA mutation. BRCA1 and 2 gene mutation are associated with the hereditary breast and ovarian cancer syndrome, which is an autosomal dominant cancer predisposition syndrome. BRCA genes are basically a caretaker of genomic stability, and inactivation of BRCA1 or 2 by germline mutation results in defect in homologous recombination repair pathway, which increases the risk for breast, ovarian, prostatic, pancreatic, endometrial, and many other carcinomas. In BRCA1 and 2 germline mutation, there is 10% risk of ovarian cancer. And the most common cancer there is high-grade serous carcinoma. The risk of ovarian and fallopian tube cancer for individuals with BRCA2 mutation is less, but the risk for breast cancer in BRCA2 is comparatively higher. Mean cumulative risk for development of breast cancer by the age of 70 was estimated to be 50% for BRCA1 mutation carriers. That's why prophylactic salpingo-oophorectomy has been recommended in these cases. Why is it recommended? To catch the cancer at the earliest phase, that is the precancerous lesion, which is serous tubal intraepithelial carcinoma. And this lesion has been found in 5 to 10% of risk-reducing salpingo-oophorectomy specimen. As I've said before, in BRCA patient, the most common cancer is serous a high-grade serous carcinoma. However, there is a certain histological appearance in many cases, which is the set pattern, which is more common in the BRCA patients. Set pattern is solid endometrioid and transitional cell carcinoma-like appearance. So this is high-grade serous carcinoma, but it may not look exactly like high-grade serous carcinoma that we see in non-BRCA patients. It is time to talk about the most important lesion in the fallopian tube, and that is serous tubal intraepithelial carcinoma, also known as STIC. So what is STIC? STIC is the intraepithelial carcinoma, which it is the precursor lesion to high-grade serous carcinoma. If you see at the top of this picture, I have nice polarized fallopian tube epithelium, which is ciliated. And if you go down, like in this area, you see that the nuclei have become larger, hyperchromatic, that is more blue, and they have lost the cilia, so it looks very different. However, if I am confused, okay, this is atypia or is it not atypia, I can take help by two stains, which are P53 and Ki67. P53 is an interesting stain. How we report it is whether it is wild type or it is mutated. What is wild type P53 staining? We call it wild type staining when some cells are positive, some are negative, and some have some degree of staining. So this is wild type staining. What is mutated? If either all of the cells are positive or all are negative. So that is mutated pattern of P53 staining. In STIC, mostly we see overexpression of mutated type of staining. Ki67 is another stain. It shows proliferative index, so it is high, usually more than 40% in cases of serous tubal intraepithelial carcinoma. This is a nice example of, I have here normal fallopian tube epithelium. Here it's becoming atypical, it's becoming so crowded, hyperchromatic, it's getting more blue. And on this side, it looks like it is not just limited to the lining, it's going down. So this is probably an invasive carcinoma. Let's look at the stains. So this is P53. And here in this area, which looked normal on histology, some staining, I can see some staining. And here in the atypical area, strong diffuse staining. Same in the carcinoma, strong diffuse staining. So this is wild type. This is mutated, overexpressed, mutated, overexpressed. Let's look at Ki67. This is normal epithelium. So I have some of the cells, they are staining positive. But here, starting from here, you can see that the proliferative index has increased. In this area, almost all cells are positive. Same in the cancer, the proliferative index is at least 60–70%. So that is how we define the serous tubal intraepithelial carcinoma, and it is giving rise to high-grade serous carcinoma. P16 is positive in high-grade serous carcinoma. However, it is not required for diagnosis of P16. However, in this case, it is positive in the in situ component as well as the carcinoma. Side-by-side picture of normal epithelium with the STIC. So here it's sort of a tangential cut. So I see cilia, I see these cells sort of orderly arranged and comparatively small nuclei. But when I go on this side, I see loss of polarization. So all the cells, they are in all different directions and they are bigger. The nuclei are much bigger and much darker in staining. This is what a classical case of high-grade serous carcinoma looks like. In the middle, I have this huge, bizarre mitosis, definitely atypical. There is a huge variation in size of the nuclei. Compare this one to this one, and this cell looks like it has 4 nuclei. Same as this one, multinucleated cells. This one, huge nuclei and so many mitosis. So this is just a classical high-grade serous carcinoma. These more than 95% of the times have extravariant disease at presentation, and prognosis depends on the stage and response to chemotherapy. Since most are advanced at the time of presentation, so they are treated with neoadjuvant chemotherapy. And these are the findings we see in the treated patients, that I have sheets of histiocytes, some hyalinizations, some necrosis, histiocyte, lymphocytes, and fibrosis also in many cases. Assessing this response is extremely important because this will determine how the next stage of treatment would be. So College of American Pathologists, it has this treatment effect score, which we have to do in cases of post-chemo serous carcinoma. And this is assessed in the tumor only, in the tumor endometrium only. So we have to give the scoring, whether it is minimal response, moderate, or marked response to chemotherapy. Risk-reducing salpingo-oophorectomy is offered to BRCA patients, and recently it has been offered to other familial cancer syndrome patients as well. And these specimens have a definite approach to them, and that is what we call the Seafim Protocol. So Seafim Protocol is something very popular, and what it means is that there is serial sectioning and extensive sampling of the fimbriated end. If this is a risk-reducing salpingo-oophorectomy, entire fallopian tube and ovary and adnexal soft tissue must go. What we do is that first we take transverse sections of the tube and of the fimbriated end. You will just go tangentially and submit everything. This approach is used in risk-reducing procedures. If there is cancer in the ovary, if it is high-grade serous carcinoma, for sure you have to use this approach, but depending on local guidelines, it is used for other tumors as well. Now coming to another type of carcinoma affecting the fallopian tube. This is the endometrioid carcinoma, definitely not as common as high-grade serous carcinoma. And it looks similar to endometrial carcinoma. So always we have to rule out primary, but it is not uncommon to see synchronous endometrial and adnexal endometrioid carcinoma. This can be associated with endometriosis. And what is the other tumor that is associated with endometriosis? Always on your fingertips, that is clear cell carcinoma. Carcinosarcoma is a type of carcinoma that we can see in a lot of organs. What it means is that the carcinoma has sarcomatous transformation. So the epithelial component is malignant, but the mesenchymal component is also malignant. Now, how would I know that this is not all carcinoma, just carcinoma? So this is differentiated, and maybe there is some undifferentiated carcinoma. That is by the cytokeratin stain. So in this image, you can see that the epithelium is positive, but the malignant mesenchymal component is negative. So this is a carcinosarcoma associated with worse prognosis. Another important and very extremely interesting entity. It's quite rare. So this tumor has this diverse morphology. It can happen next to the fallopian tube, next to the ovary, but at other sites closer to the female genital tract as well. It has a very diverse morphological spectrum. It can form tubules, nest, or gland-like structures. What is astonishing about this tumor is that though it is closely related to the female genital tract, it is negative for the female genital tract markers. And those markers are Paxate, and ERPR. And what it is, this is female adnexal tumor of probable Wolffian origin. So let me take you back to the embryology. Remember when we said that at around 6-7 weeks of gestation, the embryo has Wolffian duct and it has the Mullerian duct. The Wolffian duct in females, it involutes, but many times there are some embryological remnants. And these are the embryological remnants that give rise to female adnexal tumor of probable Wolffian origin. And because this tumor is not originating from any Mullerian precursor, so this is negative for the female genital tract markers. It is positive for CKAE1, AE3, CD10, cholinergic, and androgen receptor, which will not be surprising if you know the embryology. And it is located in the broad ligament, lacks resemblance to tumors of Mullerian origin. That is that, see, no, there are no cilia, there are no endometrial glands. So it looks very different from the Mullerian tumors. And it has a variable histological appearance. Another important thing, this usually has good prognosis. So all the more reasons for you to learn embryology and trying to find this lesion. With that, we have come to the end of this second module. I hope you enjoyed it. If you have any questions, do let me know.